Hello everyone. I welcome all the delegates who are watching this session. I thank TNMSA Academic Wing for organizing this session. I thank speaker for the today's session, Isakkirajan sir, for coming forward to take classes at the time of COVID pandemic. Thank you, sir. Now I request Jaya Vigneish sir to start the session.
Hello, sir.
So good evening, guys. And now the presenter is Dr. T. Jaya Vigneish, and he's a final year MBBS student and my junior from Government Sivangi Medical College. And I'm happy to be here. And first of all, I'd like to thank TNMSA for giving me this opportunity to see you all in this platform. So shall we go into the case, man?
Yes, sir. Thank you, sir. Yes.
Please.
Ragu, please.
Yeah.
Yes, so today's case will be on varicose veins.
Proceed, man.
Yes. Yes, sir. Shall I start, sir?
Yeah, sure.
Yes, sir. A 45-year-old female, Miss Muttumari, housewife by occupation, coming from Sivangai, came to OPD with chief complaints of dilated veins in the left leg for past 5 years, pain in left leg for past 1 year. Next slide. History of presenting illness. The patient was apparently normal before 5 years, after which she developed dilated tortuous vein in the left leg for past 5 years, insidious in onset, gradually progressive, becomes more prominent on standing and less prominent on lying down. Next slide. History of pain in left leg for past 1 year, insidious in onset, dull aching type, intermittent in nature, not radiating or effort, aggravated by prolonged standing and walking, usually towards the end of the day, relieved by lying down. Next slide. History of hyperpigmentation in the left leg for past 1 year around the medial malleolus, history of itching present, no history of ulcers, eczema or edema, no history of night cramps, no history of prolonged immobilization, no history of fever, pain abdomen, no history of trauma. Next slide. No history of abdominal distension, no history of loss of weight and loss of appetite, no history of constipation, and no history of chronic cough.
Right.
Yes, sir. So past history.
Yeah, please. Proceed, man.
No history of similar complaints in the past, no history of diabetes mellitus, hypertension, TB, asthma, epilepsy, and allergies. Next slide. Personal history, consumes mixed diet, not a known smoker or alcoholic, no history of tobacco or betel nut chewing, no history of use of OCPs, history of treatment of varicose by elastic bandage.
Okay.
Next slide. Family history, no similar complaints among family members, menstrual history, attained menarche at 12 years, regular cycles, no history of dysmenorrhea, age at first childbirth 26 years, age at second childbirth 30 years. General examination. The patient was examined after getting consent. The patient is conscious, oriented, moderately built, and nourished. Not anemic, no icterus, no clubbing, no cyanosis, no pededema, no lymphadenopathy. Next slide. The vitals were pulse, rate 80 per minute, regular, normal volume, no special character, no radioradial or radiofemoral delay, no vessel wall thickening, felt in all peripheral vessels. Respiratory rate 13 per minute, thoracoabdominal type, blood pressure 110/80 mm Hg, measured in right upper arm in sitting posture, temperature afebrile.
So Jaya Vigneish.
Yes, sir.
So from history, what may be the differential diagnosis we can go for?
Sir, the differential diagnosis is.
Can you see the slide from first?
Sir?
Can you see the slide from first? Yeah.
Yes, sir.
So, of course, you explained the pain well, and the presence of the dilated and tortuous vein for 5 years. It is a chronic case, right?
Yes, sir.
5 years means it is a chronic case. And varicose vein, whether the sex of the patient is related to it It is more common among.
Yes, sir. It is more common among women than males at a ratio of 10:1.
Okay. So then occupation. What is the role of occupation in varicose vein, man?
Sir, in cases when persons are exposed to prolonged standing, there will be increased chances of varicose veins.
Of course, good. That's a good answer. And what else we can go for? Any diagnosis, differential diagnosis from this history of the identity of patient. Occupation is more important, and sex of the patient and age of the patient is more important.
Yes, sir. Yes, sir.
In case of females, we should look for any if the patient is in the reproductive age group of people. Like the varicose vein is more common among pregnant women. Even pregnancy can induce varicose vein. So age of the patient is also more important. So next slide. Next. So here you explain the nature of the veins, right? Dilated and tortuous vein, and how it is arising, insidious and onset.
Yes, sir.
And the history of becoming more prominent on standing is more important. So next slide. Next. Here you have to mention about the claudication, man. Whether there is a claudication pain is not present or not. You have to explain.
Yes, sir. Claudication vein was absent.
Okay. Next. Okay. So hyperpigmentation means what you're coming to say here.
Sir, hyperpigmentation is caused due to hemosiderin deposition due to stasis of venous blood for prolonged periods.
Okay. So why do itching occur in case of varicose vein?
Itching occurs same due to pigment deposition. It causes.
The hemosiderin deposition, itching
Yes,
can also occur.
Yes, sir.
And the patient has no ulcer, no night cramps.
Yes, sir.
Okay. Next slide, man. Next slide. So what are you coming to say about loss of weight and loss of appetite, man? Why do you ask the history of loss of weight and loss of appetite?
Sir, it might be due to any ovarian tumors or any malignancy which might be causing varicose ulcers, varicose veins.
So here comes the types of varicose vein. There are two types, primary and secondary. And primary, it is due to idiopathic reason, and secondary may be due to maybe due to any other cause, like any mass in the abdomen. So to rule out the malignancy, you're asking the history of loss of weight and loss of appetite, right?
Yes, sir.
Okay. So next slide, please. Next slide. Past history. In past history, you should ask about any collagen disorder, or history of any vascular abnormalities is there for this patient or not. That on the history. Next. Personal history, of course. Smoking. What is the impact of smoking, man? Why it is
Smoking
important?
predisposes to DVT.
And it also has some endothelial injuries.
Yes,
Okay.
sir.
Right. Next slide. Okay. Family history. So family history of varicose vein, whether it is important or not, and where it will be important.
So it
What
may
is
be present among siblings and other family members.
hereditary disease? Varicose vein itself is not a hereditary disease, right?
Yes, sir.
Associated vascular abnormality. If any vascular, it is due to varicose vein is due to loss of elasticity, right?
Yes,
In
sir.
case of any collagen disorders, it may be present in a family, or
Okay,
any
sir.
mitochondrial disorders can also predispose to varicose vein in rare cases. So family history of any collagen disorders should be asked.
Okay, sir.
Okay, being a female patient, you're asking about menstrual history, and in family history, you should tell about the number of children and the pregnancies even. And any history of varicose vein at the time of pregnancy is more important, because pregnancy can predispose or can provoke varicose vein.
Okay,
So you should add on that history. So next slide, please. Next. Oh my God.
Ragu? Yeah, okay.
Yeah. So general examination. Okay, after getting the adequate consent from the patient or examining the patient. Nice. Next slide. Okay, vitals are stable for this patient. Next slide, please. So start the local examination one, please.
Yes, sir. Ragu?
Please.
Yes. So inspection, the patient was inspected in standing position, exposing from umbilicus to toe. And this was the image, sir. Next slide. So of inspection of a left leg, it was dilated tortuous veins seen over the medial aspect of left leg, extending from in front of medial malleolus, coursing along the medial aspect of leg up to the medial aspect of lower one-third of thigh. Hyperpigmentation of the skin over medial malleolus and medial aspect of lower one-third of thigh. Next slide. So no ulcers, edema or scars are visible, no loss of hairs, no brittleness of nails, no visible bone deformities.
Okay.
Next slide.
So
Palpation.
from inspection, what you are concluding? What we can conclude from your inspectory findings?
Sir, I could find that there were dilated veins over the left leg, which is over the medial aspect. So it probably involves the great saphenous vein.
Yeah.
And there were no ulcers. So there are no main complications.
The point I
Ask in-
was a great saphenous vein varicosity from inspection. Next, you can proceed.
Yes, sir. Palpation, no warmth or tenderness, no thickening of skin, no pitting pedal edema. Next slide. So test for varicose veins. Brody Trendelenburg test 1. Yes, sir. So observation, veins fill rapidly from above downwards, which inference as saphenofemoral junction incompetence. Brody Trendelenburg test 2. Observation, gradual filling of veins, inference perforator incompetence. Yes, sir. So multiple tourniquet west. Observation, dilated veins appear between the second and the third tourniquet, which infers below knee perforator incompetence. Fegan's test, observation, defect in the fascia felt as a pit along the course of dilated veins just below the knee, and it is marked. Modified Perthes test, not done. Percussion, Schwartz test, observation, impulse felt at the saphenofemoral junction when percus below. Auscultation, Morris's cough impulse test, observation positive, cough impulse felt at saphenofemoral junction, root not heard. Examination of peripheral arterial system, femoral, popliteal, posterior tibial, dorsalis pedalis pulses felt equally in both the limbs, lymph nodes not palpable, examination of the other limb normal.
Okay. So from local examination, and why didn't you do the modified Perthes test?
Sir, there was perforator incompetence, so it is contraindicated.
Why? Reason?
Sir, because there is perforator incompetence, we can't distinguish between DVT and there will be both same findings, sir, so we can't.
Modified Perthes and both tests are contraindicated in case of presence of DVT. Because how will you modified Perthes test, man?
Sir, we'll put a tourniquet below the saphenofemoral junction.
With milking or without milking of the limb?
Without milking, sir.
Okay. At the saphenous junction, you are tying a tourniquet, and then
yes, sir. And then I will
walk.
yes, sir.
As you're tying a tourniquet in the just above the saphenofemoral junction, you are blocking or you are obstructing the flow in the superficial system.
Yes, sir.
So, while patient is walking, the venous pressure will increase and the blood will flow in the deep system only.
Yes, sir.
If the deep venous system is patent. In case of presence of DVT, there will be a throbbing pain.
Yes, sir.
And the varicosities will become more dilated because the flow in the deep system will be obstructed by the thrombus, and you are obstructing the superficial system.
Yes, sir.
This modified Perthes test is to detect the presence of any DVT.
DVT. Yes, sir.
Okay. In case of presence of deep venous thrombus, there will be a throbbing pain. That will be the inference.
Yes, sir.
In case of presence of DVT, if the patient is a case of known case of deep venous thrombosis, we should defer this test and we should not do this test. Otherwise, to detect any presence of DVT, we can go for it. I don't think that presentor incompetence is a contraindication for it.
Okay, sir.
Okay. So how will you do the Trendelenburg test? Goody's Trendelenburg test. How to do it?
Sir, first I'll ask the patient to lie in a recumbent position and I'll milk the veins.
Okay.
Sir, and then I'll apply a tourniquet above the below the saphenofemoral junction.
Okay.
And when I ask the patient to, when I remove the tourniquet, there will be a sudden feeling of veins from above downwards, which indicates the saphenofemoral junction incompetence.
Next.
This is as a test 1. Test 2, I'll tie the tourniquet below the saphenofemoral junction, and I will ask the patient to stand for 1 minute. If there is gradual filling of veins, it indicates perforator incompetence.
Okay. So saphenofemoral junction. What
Yes,
is saphenofemoral junction?
So the junction where the saphenous vein drains into the femoral vein.
Okay. Where the great saphenous vein drains into the femoral vein.
Yes, sir.
Where it is located? Its anatomical landmark. Can you mention it?
It is located 4 centimeter below and lateral to the pubic tubercle.
Okay. In the saphenous opening. Okay.
Yes, sir.
So 4 centimeter below and lateral to the pubic tubercle. So
Yes,
the
sir.
exam of the patient, you should locate the trait. So how will you locate the pubic tubercle?
Sir, by bony landmark near the pubic symphysis.
So you have to locate the pubic tubercle. What you have to do is that you should ask the patient to adduct the lower limb against resistance. While
Okay, sir.
adducting the lower limb against resistance, the adductor longus muscle will become taut. And while
Yes,
tracing the muscle, you can reach the pubic tubercle. This is
okay,
how
sir.
you can detect the pubic tubercle. And from pubic tubercle, 3.5 to 4 centimeter below and lateral, you can find the saphenofemoral junction. So
Yes, sir.
what are the tributaries of tributaries that is seen near the saphenofemoral junction, just near the saphenofemoral junction?
Sir, superficial external potental, superficial epigastric, superficial circumflexiliac.
Nice. Yeah.
Yes, sir.
Tributaries.
Yes, sir.
Okay. So what is the importance of Morrissey cough impulse test?
So Morris's cough impulse indicates incompetence at the saphenofemoral junction. When the person coughs, there will be a bulging of the saphenofemoral junction, which indicates its incompetence.
Okay. What is the importance of what else? Then okay, why don't they do Perthes test nowadays? And why are going for modified Perthes nowadays? Both are to detect TVTs, and this test will be somewhat severely painful, and the patient compliance will be poor, and also it can lead to disclosement of the thrombus.
Okay, sir.
So we are going for modified Perthes test.
Okay.
Okay, then proceed. What else? Other system examination.
So other system examination, abdomen inspection, no dilated veins or visible swellings or mass, palpation soft, non-tender, no organomegaly, no mass.
Hello.
No serious S1 S2 hurt, no murmur, no focal neurological deficits.
Okay, what is the importance of other system examination in varicose vein?
Sir, in case of any abdominal tumors or mass, then it might cause compression and it might be a secondary cause to varicose veins.
Right. Okay. So next proceed.
So next slide. Next. Ragu, hello.
Hmm.
Yeah, okay. So diagnosis.
Please.
Sir, a case of primary varicose veins of the left lower limb involving the great saphenous vein with saphenofemoral incompetence and below-knee perforator incompetence with pigmentations. CEAP classification C4, EP, A, S plus P, PR.
Here you have to add whether there is a presence of DVT or not, and whether there is ulcer or not should also be added to diagnosis.
Okay, sir.
Primary varicose vein of left lower limb involving the great saphenous vein with superficial with the saphenofemoral incompetence and below knee perforator incompetence with skin involvement like hyperpigmentation, with
Yes,
no
sir.
ulcer and with no signs of deep venous thrombosis.
Okay, sir.
So, what do you mean by CEAP classification? Abbreviation of CEAP?
So, CAP class in clinical etiology. Hello, sir.
Yes, yeah, proceed, man. Clinical etiology, then
And
anatomy.
anatomic pathophysiology. Yes.
Okay, P4 means what you're coming to say.
So C4 means the skin changes are present, sir. Pigmentation is present. So the clinical getting a C4, sir.
Okay,
And EP means it's a primary, not any secondary causes. So I classify as primary.
okay,
Etiology is primary. And anatomically, both superficial and perforator veins are involved. So S and P, sir.
okay.
And in case of pathophysiologic reflex dysfunction, so I classify as PR, sir.
So, what are the other pathophysiological causes?
It may due to obstruction,
Obstruction of,
sir.
obstruction of
Obstruction of the deep vein system.
deep vein or any superficial vein or any major vessel obstruction can also lead to varicosity.
Okay,
So,
sir.
where are the other locations where we can see varicosity?
So we
Varicosity
can see
means
varices in
obvious.
esophageal varices, gastric varices, hemorrhoids,
Okay,
and testicular varices, ovarian varices, vulval varices. Yes,
okay. Then one more. In portal hypertension, we can see even
sir.
anterior abdominal wall.
Caput varices.
Yeah, anterior abdominal wall also you can see the varices. So next slide.
So
Okay.
investigations.
Mm.
So routine investigations, complete blood count, bleeding time, clotting time, blood grouping and typing, blood sugar and urea, serum creatinine, urine sugar albumin, LFT, and ECGs.
What is the importance of these investigations?
So to rule out any other pathologies, underlying secondary causes.
Okay. And also in case to evaluate the general condition of the patient and to
Okay.
improve the general condition of the patient, you are supposed to see the hemoglobin of the patient and other abnormalities even. Next.
Oh. Next slide. So for diagnosis, duplex ultrasonogram, handheld Doppler, venogram.
What is duplex?
So duplex is both Doppler and B ultrasounds.
B mode of ultrasound.
B mode
Okay,
of
what
ultrasound.
we can see in duplex?
So we can see reflex and obstruction, retrograde and antegrade flow of blood.
Okay. Colors, can you mention any color? How we can
So
differentiate antigrade?
blue is used to represent antegrade flow, sir, and red is for the reverse flow.
Okay, nice.
Yes, sir.
So what else? Doppler, venogram. Venogram, what is venogram?
So venogram, a contrast medium is injected into the vein and we see any obstruction or anything.
Okay. So what else we can do, man?
Sir?
What are the other sophisticated investigations?
There are other investigations.
You can go for even CT and MR angiographies.
Yes, sir.
And what else? Other investigation. Next slide.
Next slide.
Other investigations.
Other investigations.
Rule out
Such
some
chest
secondary.
X-ray.
Yeah.
Chest X-ray.
Why?
Sir, to rule out any COPD, which might be causing chronic cough, which could have lead to varicose veins.
So chronic cough, how it leads to varicose vein?
Sir, constant coughing increases the intra-abdominal pressure, which causes an incompetence at the saphenofemoral junction.
Okay, chronic cough, it may lead to obstructive pathology, not reflex pathology.
Okay, sir.
Chronic cough with increased intra-abdominal pressure can lead to obstructive pathology of
Okay,
varicose. Okay. Next, what are other investigations?
Other investigations.
Ultrasound abdomen can be done
Yes, sir.
to rule out secondary causes like any liver tumors, any abdomen tumors, ovarian tumor.
Okay. Yes, sir.
Okay. So what you're coming to say about, so final diagnosis will be primary varicose vein, right?
Yes, sir. Yes, sir.
Your GSV is involved, GSV territory is involved, great saphenous
Yes, sir.
vein territory is involved with
Yes, sir.
saphenofemoral incompetence and perforator incompetence.
Incompetence. Yes, sir.
So female patient, as
Yes, sir.
usual, for female patients, we will give some extra importance for cosmetic appearance of scar, surgical scar.
Yes,
So
sir.
treatment, what you prefer, man? What is the
Sir,
preferred treatment for this patient?
Sir, first I would like to manage it conservatively by bandage and
Okay, what is the
dressing.
indication for surgery in varicose veins? Absolute
Indication,
indication for surgery.
sir, absolute indication is um, symptomatic, sir. If the patient is very symptomatic and pain, we can go for surgery.
Okay, in the clinical, when CEAP classification, which category of clinical category will say absolute indication for surgery? C3 is an absolute indication for surgery.
Okay. Yes, sir.
So what is C0?
So C0, no
C1.
visible tension. Yes, sir. C1 is telangiectasia or reticular veins.
Okay, C2.
C2 is varicose veins. C3 edema.
Okay, and the C3, the presence of edema, C3 is an absolute indication for surgery.
Okay, sir.
And C4, it's a skin involvement. So here we have the patient in C4 with skin involvement. So this
Yes, sir.
patient satisfies the criteria for surgery, and she needs surgical treatment for varicose vein.
Okay.
So what surgery can do for this patient with femoral incompetence and perforator incompetence? So what you prefer to do?
Sir, for the saphenofemoral incompetence, I'll go for a flush ligation with the stripping of the GSV up to the knee. And for perforator incompetence, I'll go for subfacial perforator ligation on the left lower limb.
Okay. So what does saphenofemoral flush ligation means? Flush ligation means?
Sir, if we ligate a little away from the saphenofemoral junction, then there might be saphenovarix, which again cause due to incompetence. So we must ligate before the.
No, we should ligate. We should flush that junction and should ligate the three named tributaries like superficial epigastric, external pudendal, and circumflex ciliar. Just
Yes,
close to the junction. If we leave a small amount of stump and we ligate it, it may lead to saphenovarix. With what is saphenovarix, man?
Sir, an edema, dilation of the saphenofemoral junction.
Dilated, stumps will dilate because of pooling of blood. So we should
Yes,
ligate it just close to the junction of the vein, varicose.
yes,
That is flush ligation. So how will we make an incision for this case, for varicose vein incision?
along the medial aspect.
It's an oblique incision just below the inguinal ligament, starting from, we'll just palpate the femoral artery from femoral artery pulsation to 4 centimeter medially, oblique and parallel incision. We can get this point. We will just palpate the inguinal ligament.
Yes,
Okay,
sir.
just below it, an oblique incision starting from the pulses, femoral artery pulsation 4 centimeter medially.
Yes, sir.
From femoral artery pulsation to 4 centimeter medially, oblique incision below the inguinal ligament.
Yes, sir.
So we'll just open the. And why do you want to strip the GSV only until knee?
Sir, if you,
femoral flush ligation with stripping of GSV up to knee. Why not
yes,
below?
sir, if you go below the calf, then there might be injury to the nerves like the saphenous nerve.
Yeah.
So
Below in the leg, the GSV is closely running along with the saphenous nerve. So if you're trying to strip it below the knee joint, you may even cause saphenous nerve injury. So what can be done in that area?
sir, in that area, I can go for a perforator ligation, sir, and bandage or management.
Perforator ligation is the best option.
Yes, sir.
So before surgery, the patient should be marked for perforators. Usually in our setup, we will ask the radiologist to mark it by Doppler ultrasound. With Doppler ultrasound, we will mark the perforator site, and there we will go for hook phlebotomy, also called as tab avulsion technique.
Yes, sir.
Or in case the varicosity is very big, you can go for phlebotomy even. Phlebotomy means vein removal of vein. That's all.
Yes, sir.
So if the patient is not willing for surgery and the varicosities are less, Okay, or else we can keep as if we have the TNMSA surgery is done for that patient.
Yes,
Plus
sir.
like it's done, still some more varicosities are there.
Yes, sir.
What else we can go for or we can do for this patient? For some
Hook
peripheral incompetence. Hook phlebotomy. Okay.
Yes,
If
sir.
it is not willing for surgery, what are the other sophisticated treatment options available at present?
So we can go for endovenous laser ablation, radiotherapy ablation.
So under what anesthesia we will go for these surgeries? Endovenous laser ablation and radio frequency ablation.
TNMSA anesthesia.
Okay, Timothy. What is Timothy? And how will you put Timothy?
No idea, sir.
Timothy is a anesthetic fluid. It will around 450 ml of ringer lactate orally will take, and we
Yes,
will add a 1% lignocaine to it with adrenaline and soda bicarbonate.
Yes, sir.
It contains ringer lactate with 1% lignocaine and adrenaline and soda bicarbonate.
Okay, sir.
Before doing the endovenous laser ablation, we will just inject this tumescent.
Yes, sir.
And we will just so that it provides there are two uses of this tumescent. One is that while giving laser ablation technique, using laser ablation technique, it will provide equal contact to the surface of the veins. And next, it provides some anesthesia effect. So we'll go for tumescent with the IV sedation. Okay.
Yes,
So
yes, sir.
tumescent preparation is with ringer lactate, soda bicarbonate, lignocaine, and adrenaline. Okay.
Yes, sir.
So if the patient is not willing for surgery, what are the other modalities of treatment available? And small perforator incompetence alone is that. Small varicose veins.
Very good. It's,
What is Schwartz test? Why do you perform Schwartz test?
Sir?
Schwartz test.
Yes, sir.
Percussion. What is
Yes,
Schwartz
sir.
and who will perform Schwartz test?
Sir, for perfect incompetence, we palpate percuss along the fascia, sir.
That is begun.
Sir?
Okay, continue, man.
So
Continue.
when we percuss, then impulse will be felt at saphenofemoral junction, sir.
Okay. This Schwartz test will be positive only in case of large varicose veins.
Okay,
Okay,
sir.
just palpate in septophemoral junction. I will just tap over the varicose vein. We can feel the impulse. This will be positive only in case of large varicosities. If the
Yes, sir.
Schwartz test is negative, and the varicosity is very small,
Yes, sir.
and patient is not willing for surgery.
Sir,
What we can do for this patient?
compression hosiery.
Okay. What else? I have to give some curative for this patient. You can go for some sclerotherapy, right?
Yes, sir.
What is sclerotherapy? Types of sclerotherapy.
Sir, foam sclerotherapy.
Okay. Okay, foam sclerotherapy. What are the agents that are used to create the foam?
Not great idea.
We will use some sodium tetradecyl sulfate. Okay.
Okay, sir.
This is also called injection sclerotherapy or foam sclerotherapy. Here you will use sodium tetradecyl sulfate,
Okay,
and
sir.
you will add air to it
Yes, sir.
to create the foam. And by creating the foam, we will first initially we will mark the perforators, and
Yes,
we'll
sir.
start from and we'll just inject it foam and sclerotherapy agent into the perforator, dilated perforator, and we'll just do a tight compression bandage.
Okay, sir.
Can you explain me how it works? Sclerotherapy works.
Sir, it is a non-endothermal technique, sir, and
This sclerotherapy agent will cause fibrosis, will cause some endothelial injury,
yes, sir.
and while you compress it tightly, there will be collapse. The vein will collapse, and the injured endothelium of the vessel will be in contact. This
Yes, sir.
causes fibrosis and total occlusion.
Okay, sir.
But the failure rates are also common. The risk of recanalization is also present in case of injection sclerotherapy.
Yes, sir.
And can you tell me some complications of injection sclerotherapy?
Sir, complications, sir. Recurrences
Recurrences
and
can occur, and
yes, sir.
there will be extravasation of the sclerotherapy agent can cause severe pain, and pigmentation can occur. The hyperpigmentation can occur.
Yes, sir.
That if you're injecting it just beyond if you're not injecting it into the vessel, and if the sclerotherapy agent extravasates from the vessel, it can lead to severe pain, and hyperpigmentation can occur, and it can
Yes, sir.
even provoke some thromboembolus, and it can lead to even pulmonary embolism, and it
Okay.
can provoke DVT.
Yes, sir.
So, what are the contraindications for using this injection sclerotherapy?
Contraindication.
As it can provoke DVT, if the already patient has DVT, we should not use this.
Yes, sir.
If the patient is allergic to this drug, sodium tetradecyl sulfate, we should not use this.
Yes, sir.
Okay. So, radiofrequency ablation, right? One more technique for treating that. What is the temperature that is produced in radiofrequency ablation, and how will you do that radiofrequency ablation?
Sir, an electromagnetic current is used to create that heat, sir.
So first, you should canalize the vein.
Yes, sir.
The vein should be canalized, and the radiofrequency catheter will be introduced.
Yes, sir.
You should inject some Timosant and IV sedation. Initially, first of all, the patient should be educated and explain about the techniques available and what all the treatment he can afford.
Yes,
I
sir.
explain the condition of the patient. If the patient is belonging to C4, the patient should be explained about about the varicosity condition of his own condition, and
Yes, sir.
what are the treatments that can be given for this condition, and the patient has the rights to select his own treatment.
Yes, sir.
As per the ethics, nowadays we can advise the patient what all the things available and what is the best thing for him to do. But it is himself to decide what to do.
Yes, sir.
Okay, so in radiofrequency ablation, we will just inject the Timosant, and we will canalize the vein and inject this Timosant, and we will introduce a radiofrequency ablation catheter inside it. And by creating a radiofrequency, there will be a temperature of around 120 degrees Celsius will be produced. And this 120 degrees Celsius is hypothermia will cause what it may cause protein denaturation and fibrosis.
Yes,
And
sir.
the vein will collapse.
Yes, sir.
What are the complications in radiofrequency ablation?
Sir,
It produces hypothermia, right? Excess heat is produced.
yes, sir.
So this excess heat can cause damage to the adjacent organs.
Yes, sir.
And skin injury can also be present, and any other thermal injuries can be created because of radiofrequency ablation if not properly used.
Yes, sir.
Here, the Timosant plays the main vital role, and this Timosant injector will have three roles. It protects the adjacent organ from thermal injury. It helps in spreading the thermal power equally in the vessel wall, and also it provides some local anesthesia to the vessel.
Yes, sir.
And the efficacy of radiofrequency ablation is higher when compared to endovenous laser ablation.
Yes, sir.
This efficacy of radiofrequency ablation is higher than endovenous laser ablation. So here, in case of endovenous laser ablation, the same technique is followed. We will just canalize the vein. After canalization of the vein, we will inject the Timosant, and we will introduce the we will introduce the laser catheter inside it, and we will apply the laser. The laser
Yes,
will
sir.
cause denaturation of protein and will cause fibrosis of the vessel.
Yes, sir.
So these are the sophisticated techniques that are used now.
Yes, sir.
And but nowadays, as a general surgeon, and we are going to perform some Trendelmark, that is SF junction and SF junction flush ligation, and we'll go for stripping of vessel, right?
Yes, sir.
What are the what name? Can you name the strippers that are used? Name of the strippers that are used to remove the vessel.
Sir, hello.
Name of the stripper we are using, man, nowadays.
Stripper.
Commonly used for. We're going for Meyer stripper. MEYER. Meyer stripper is commonly used
Yes, sir.
with the bullet. Here, as I told you earlier, the incision will be made an oblique incision below the inguinal ligament, starting by palpating the femoral artery pulsation 4 centimeter medially. I will
Yes, sir.
expose the saphenofemoral junction,
Yes,
and I
sir.
will just flush ligate the three known named vessels like superficial epigastric, superficial external pudendal, and superficial epigastric vessel and circumflex iliac vessel.
Yes, sir.
After ligating it, I will just canalize the GSV.
Yes, sir.
I will use the stripper into it, and I will just palpate the end of the stripper till the knee joint, and at the just below the knee joint, I'll just take the stripper out by making a
Yes, sir.
small incision at the region. And getting the stripper out, I will just introduce a bullet over it, and I will do
Yes,
the
sir.
phlebotomy. The vein, I will just incise the vein, and I will just ligate the distal end, and proximal end will be within the stripper. And
Yes, sir.
after putting a bullet over the end of the stripper, I'll just pull it from the saphenofemoral junction so that the entire vein, along with its small tributaries, will come out.
Yes,
Will
sir.
be pulled out, like it will be avulsed out. You can even say.
Yes,
After
sir.
introducing the stripper inside, I just take the stripper from outside from the below the knee joint. I'll just introduce stripper at the SF junction into the great saphenous vein, and I will remove the stripper out from the one end from the below the knee joint, and I will connect a bullet over it, and then I will just pull the stripper from the saphenofemoral junction so that the entire vein will be avulsed along with the small tributaries and perforators. And I'm not doing it below the knee joint because there is a close relation. It runs in close relation with the saphenous nerve. To prevent the injury to the saphenous nerve, I'm not stripping the GSV just below the knee joint in the leg. So if
Yes, sir.
in case there's the presence of GSV varicosity of GSV just below the knee joint, what can be done?
Sir, hello.
If the perforator, if the GSV is incompetent, even below
Yes, sir.
the knee joint, you can go for some
Sir.
injection sclerotherapy can be done.
Okay, sir.
This injection sclerotherapy can be done under local anesthesia, whereas the stripping should be done only under spinal anesthesia to prevent pain. That is what commonly we are doing here.
Yes, sir.
So, what are the complications of varicose vein?
The complications of varicose vein is mainly due to dilation. We have hemorrhage,
Okay,
sir. Hemorrhage, thrombosis, and calcification of veins. So, it might also lead to ulcer formation, varicose ulcers, which might also lead to malignant change, which is marginal ulcer.
what is the
And
common site of varicose ulcer?
sir,
What is the common site of venous ulcer?
medial aspects, medial malleolus.
Okay, the name of the zone is also called as Gatus zone.
Yes, sir.
Okay, so what will be if there's a hemorrhage, there's an extensive sprouting hemorrhage from the venous ulcer? What will be the treatment for this?
Hemorrhage.
Prefer a treatment for venous bleeding
Yes,
over the
sir.
extremity. What we will do? For example, if you're going in a roadway, there's a patient with varicose vein in a road.
Yes, sir.
Patient is bleeding from his lower limb, maybe near that medial malleolus. He's having a extensive bleeding hemorrhage, and you are there in a road. What you will do?
Compression.
It is
Yes,
a
sir.
venous hemorrhage.
Venous.
It can be done. Of course, compression.
Raising of like.
Yeah, compression can also be helpful, but to completely avoid the hemorrhage, you should just limb elevation is more important.
Yes, sir.
More than compression, you can go for limb elevation.
Okay, sir.
So, what is the treatment for varicose ulcer?
So treatment is we can go for excision of the ulcer with the graft.
Okay. So, what is the regimen used in case of varicose ulcer treatment?
Um, sir, this Bisgard's method.
Okay. What are the components?
Sir, must clean the ulcer with a normal saline, povidone iodine, and hydrogen peroxide. And then we must remove any slough over the ulcer. And we can give any antibiotics and exercises should be taught. We can also give a 4-layer bandaging system.
Okay. What should be the pressure of the compression stocking you're advising the patient, man?
Sir, around 40 millimeter mercury.
35 to 40 millimeters of mercury.
Yes, sir.
So what determines this pressure? Why it is 35 to 40?
Sir,
What
compress
is
the vessels.
hypertension?
Sir?
What is venous hypertension?
Sir, pressure exerted on the venous system.
Okay. So what is ambulatory venous hypertension?
Sir, while walking, the calf muscle pump mechanism causes hypertension.
So what is normal physiology of venous return from the leg?
Sir, the calf muscle, sir?
Normal physiology.
Sir, it acts as a peripheral pump, and while a contraction, it pushes the blood from the lower leg to the heart, sir.
So initially, what will happen is that the blood will get pulled in the lower limb, and it will be in a superficial venous system.
Yes, sir.
While we are walking, there will be a contraction. So that what happens is that deep vessel blood in the deep vessels will pump out. Okay.
Yes, sir.
At the
Yes,
same time, the superficial system will be filled with blood.
yes, sir.
While relaxing, the blood from the superficial system will get into the deep system through the perforators. Okay. As the perforators are valved vessels, most of the, veins are valved, right? So that there will be no backflow from deep venous system to superficial venous system normally.
Yes, sir.
So while walking, when patient's leg is in relaxed position, there will be flow of blood from superficial venous system into the deep venous system. Okay, and while patient is walking, the calf muscles will contract, and the blood vessels from the deep venous system will be pumped up, and then after relaxation, it will come the blood from the superficial system will enter into the deep. This is how the blood flows into the in the lower limb. Okay, venous blood.
Okay,
In this case, the perforator love vessels, so this prevents the backflow of the blood from the deep venous system to superficial venous system. In varicosities, there will be fault in the valves. So, in perforator incompetence, while contracting, the blood flows out from the deep venous system to the superficial venous system.
Yes, sir.
While the calf muscle contracts, the blood flows from the deep system to the superficial venous system. Okay,
Yes, sir.
so what are the other advices you will give the patient?
Sir, I'll ask the patient to not more prolonged standing causes varicose veins. I'll advise the patient to walk more frequently, exercises, and compressive hosieries could be advised.
Okay. Compressive hosieries, what time it will be advised?
Sir, during night time and during standing.
During standing. Okay.
Yes, sir.
So, okay, why that? What about claudication pain, man? Where it occurs?
So claudication pain occurs in the calf muscles, calf due to deep vein thrombosis.
What is claudication pain? How it will be? What is the nature of claudication pain?
It's a burning type of pains.
Morning,
Yes, sir.
how patient explains it? Usually in claudication pain, the patient can walk for a while and he'll get a pain and you have to sit. And then he'll walk a few more meters and he will take rest.
Yes, sir. It's a bursting type of pain.
This is the exact word that the patient will explain about a claudication pain. He
Yes,
can
sir.
walk for a while, and after that he couldn't walk because of the pain, and then he will just stop. This is seen in DVT. The nature of pain in varicose vein is like night cramps, right? Why it occurs as night cramp? In varicose vein, as explained, what is the fibrin cuff theory and other WBC trapping theory? Can you explain the fibrin cuff theory, man?
Sir, fibrin cuff theory, there is due to increase in venous pressure, there is an increase in the size of the capillary bed, sir, and it causes an increase in the widening of the interstitial pores. So
Okay.
therefore, a fibrin gets deposited around the capillaries, which causes hypoxia, sir, because the diffusion is damaged, it is interrupted. So it causes a local hypoxia and ischemia.
Okay, because of local ischemia, if patient starts in morning and he's starting walking, there will be localized hypoxia, and towards the end of the day, the hypoxia will be more severe and there may occur pain. This leads to night pain, night cramp in this patient. So this will be a classical thing. The
Yes, sir.
patient will complain of night cramps. This is because of localized hypoxia. Okay.
Yes, sir.
So what are the role of antibiotics when post-op wound infection? What do you expect post-op wound infection?
So post-op wound infection is the most common complication after surgery, sir. So I will advise prophylactic antibiotics.
Not doing the surgery properly. Surgery should be done perfectly.
Yes, sir.
Aseptic precaution, sterile measures should be done, and post-op antibiotics are usually not advised. Even in any cases, there will be just pre-op antibiotics, single dose of pre-op antibiotics enough in most of the cases. Only in case of septic cases, we should go for post-op. But in our setup, we are going for post-op antibiotics. But ideally speaking, you should provide a sterile aseptic surgery, and here there should be no post-op antibiotic. Only one dose of pre-op antibiotic is sufficient.
Okay, sir.
As per theory, but we are giving this post-op antibiotic.
Yes, sir.
So can you just summarize what about varicose vein? So a
Yes,
patient
sir.
is
So,
no, I'll make it, man.
yes, sir.
45 years female is coming with you with the history of night cramps and pain with limb edema. On examination, you are finding the varicose vein. Okay. On examination, you find the varicose vein. Female patient are predisposed to varicose vein in the age of at the pregnancy age. I mean, a reproductive age group of people will be involved. And females are more commonly involved because of what are the hormones. Hormonal influence in female is more important. In pregnancy, there will be release of estrogen and the relaxin will be more. So you know about the hormone relaxin, right?
Yes, sir.
That will cause relaxation and dilatation of all muscles. And estrogen itself has an effect on the collagen. So this pregnancy, in pregnancy, the varicose vein is due to that hormonal effect, like estrogen and relaxin hormone. It will have direct effect on the vessel wall, vessel epitheliums. So the sex of the patient is more important, and the males are more commonly involved because of smoking habit. Smoking causes varicose vein and predisposes to varicose vein in most cases, and males are commonly involved at the older age group because they have occupational predisposing factors like prolonged standing and prolonged driving factors. Driving, like vehicle drivers and car drivers, bus drivers are commonly involved because of their occupational hazard. And edema of the patient. So after patient, we are receiving the patient, will just examine the varicosity and we'll see the side of the lesion. In case of left and left side, a medial aspect or lateral aspect, you'll go for it. In case of medial aspect extending up to the thigh region, it may be a great venous vein territory is involved. In case of lateral side, involving just below the knee, you should go for a short venous vein territory can also be detected. Should be suspected. And after suspecting the varicose vein clinically, I'll go for CEAP classification. And if the patient is T3, if edema is present, I will just explain the patient that it is an indication for surgery. If not, even C2, varicose vein is present, patient is willing for surgery, you can go for surgery. If the patient is not willing for surgery and he needs some conservative management, I will go for elastoc rib bandage and compression stocking and limb elevation will be advised until and unless patient develops ulcer or any other complications. So initially, on receiving the patient, I should rule out the other complications like DVT and venous ulcers. Okay. In case of presence of DVT, should I go for stripping? In case if the DVT is present, we should not do surgery for this patient. because if the DVT is present, the deep venous system is totally obstructed because of venous thrombus. If you're stripping the superficial vein, GSV, then there will be no way to flow, no way for the blood to flow out of the limb. Hope everybody can understand. There will be arterial flow towards the limb and venous flow away from the limb. In case of presence of deep venous thrombosis, the deep venous system is obstructed. If I'm doing a surgery for this patient without knowing that the patient is having DVT, I'll strip the superficial system also, then there will be no venous flow from the lower limb. This will lead to limb edema. Not only limb edema, patient can go for even we can lose the limb of the patient because of limb edema. Further limb edema will cause occlusion of even arteries and gangrene can even occur. So we should rule out DVT of this patient. And what are the contraindications for surgeries are? The most absolute contraindication is that DVT, and second contraindication is secondary varicose vein. If the patient is having any abdominal mass or any other secondary cause for varicose vein, the secondary cause should be treated first, followed by surgical removal of varicose vein. If not, you should not. In case of presence of any secondary causes, the surgery should not be performed. So you should treat the secondary cause. Even treating the secondary cause can resolve the varicose. Varicose vein can be resolved by treating the secondary cause. For example, if a patient has an abdominal tumor with varicose vein, just removing the abdominal tumor can relieve the pressure, and the varicose vein can also resolve. Because in such cases, the reflex in the pathology in CEAP classification, if any tumor is present obstructing or occluding the vessel, it comes under obstructive pathology. Just by relieving the obstructive pathology, it can be normalized because the valves will be normal in this case. Okay. So it should rule out any secondary causes, and DVT is ruled out, and there is no secondary cause. If the patient is diagnosed with primary etiology, I should even go for chest X-ray, even for anesthesia purpose, anesthesia fitness purpose, and also for any other COPD changes. And at present situation, chest X-ray and CT test is more essential to rule out COVID infection. Should even rule out COVID infection, and of course, everybody should know that COVID can even lead to venous thrombosis. Any thrombosis can occur because of COVID. COVID-19, coronavirus can even cause vascular embolization. So nowadays we should go for even CT chest and X-ray chest is done to rule out COVID-19 infection, and then I'll go for any ultrasound abdomen to rule out any abdominal masses or any organomegalies, and ovarian pathology, rule out any ovarian pathology and uterine pathologies, and then I'll go for duplex scanning, which is more sophisticated. In case if I have a duplex scanning with me, I won't go for a venogram, which is invasive, and the injecting dye is more. It has its own risk factors. So if duplex is available, I'll go for a duplex scan. Duplex scan is useful to delineate the anatomy and to mark the perforators. So the entire anatomy of the vessel can be delineated by duplex scan, and the perforator can also be seen. So the incompetence of the perforators are also seen by me, and then I will just offer the treatment options available to the patient, which he suits up. If the patient is not willing for surgery, in case of small veins, I will go for small varicosities. I will go for injection sclerotherapy. I will use sodium tetradecyl sulfate sclerotherapy foam agents for this patient. And if properly injected, it has a good efficacy. And after injection, I will go for a compression elastic rib bandage. Compression dressing for this patient for 2 days. And after the 2 days, I will ask the patient to wear an elastic rib bandage. And of course, even after just injection, we should ask the patient to walk. In case of while doing the injection sclerotherapy, the patient should move out of the theater by walking on his own, so that by walking, the injection sclerotherapy which we inject will spread evenly to all areas. So if the patient is willing for surgery and is fit for surgery, I'll go for go for flush ligation of the saphenofemoral junction, as mentioned earlier, and the stripping of the great saphenous vein till the knee joint using a Mayer stripper. And if case of any varicosities, if the short saphenous vein varicosities are present, if the short saphenous vein varicosities are present, you can go for phlebotomy even, or injection sclerotherapy itself will be enough for these cases. Injection sclerotherapy or phlebotomy. In case of reticular veins or minor, small varicosities, multiple small varicosities, we can go for hook phlebotomy, also called as tab avulsion. Here, hook is used. OESCH, hook is used. A small stab incision is made right over the varicosity, and mosquito artery can be used, or a hook phlebotomy hook can be used to hook out the varicosity, and we can just avulse the varicose vein, and even we need not suture that wound. We just give a compression elastic grip bandage alone is more than enough. This is hook phlebotomy or stab avulsion. In case of small varicose vein, small varicosities, we can go for it. In short saphenous vein varicosities, we can go for injection sclerotherapy or phlebotomy. We can make an incision along the course of the vein, and we can just do a phlebotomy. We'll tie that other ends, and we can go for phlebotomy. And post-operatively, I'll have a tight compression stocking for 2 to 3 days. And after 3 days, I'll advise a patient to go for a elastogrip bandage. The complication I can expect is that limb edema. So tight elastogrip bandage is required to prevent this limb edema, and limb elevation is more than enough for this patient. And we can mobilize the patient to prevent that edema. This is how we will treat a patient of varicose vein. And of course, varicose vein is the most easiest case in final practical exam, because the number of questions will be very less. And even if they ask, it is answerable questions. So even my final year surgery exam question is, exam case is a varicose vein. It was a very easy thing for me. So I prefer to take a varicose vein as a long case. In post-operative antibodies are not required in these cases. So any questions, man?
Sir, there are
Hello?
There are a few questions in the chat box, sir.
Okay. So night cramps, as I explained earlier, the pain in the varicose vein is due to local hypoxia. And the hypoxia is not that severe to cause the immediate pain. Like as the presenter said, the fibrin cuff theory, in case due to the stasis of blood in the lower limb, there will be extravasation of blood, and this causes the localized inflammation, and fibrin deposition can occur. This fibrin will form a layer between the tissue and the capillaries, and this fibrin layer reduces the diffusion of the oxygen or other material from the vessel to the tissues. This will cause localized hypoxia. As the patient keeps on working from day to day, he will start develop pain severely at night. As patient keeps working, the muscles will be utilizing its own. There will be anaerobic mechanism, and lactic acid accumulation will be there. This will cause pain at night when patient is taking rest. This is how the night cramp appears in the varicose vein. As usually we work in day and we are sitting in night, we are taking rest at night, we are aiming it as night cramps. Even if a person fully works at night time and if he goes for rest at daytime, he will develop cramps at daytime. This is due to localized tissue hypoxia and estrogen. As I told you earlier, in pregnancy there will be a hormonal influence that leads to varicose vein. And this card regimen is already explained by our presenter. And chronic ambulatory venous hypertension, it is a more important thing. Okay, I'll come to it later. Management of short saphenous vein varicosity. Okay, as I explained earlier, in case of short saphenous vein varicosity, we can go for injection sclerotherapy if it is injection sclerotherapy, or you can go for phlebotomy. In case of small varicosities, you can go for a hook phlebotomy or a tab avulsion technique. So chronic ambulatory venous hypertension in varicose vein. It is a main pathophysiology and it's the most important topic and the most commonly asked question. So, ambulatory venous hypertension. Usually the hello. Okay. Hope I'm audible, man.
Sir, sir.
Chronic ambulatory venous hypertension is the main cause for varicose vein, man. In case of ambulation, means while walking, the pressure in the venous system will increase. As I told already, while walking, the pressure in the deep venous system will increase while the muscles are contracting around more than 200 millimeter of mercury, so that the blood will be pushed up from the deep venous system. In case there is a chronic venous hypertension, chronic pressure is more chronically present, the perforator valves will become incompetent. The chronic, while walking, the pressure inside the deep venous system will be relieved when the blood is pushed up. If the blood is not pushed up, if the blood is stagnant in the deep venous system, the pressure will be more high. This will cause reflux into the perforators. Okay, so chronic ambulatory venous hypertension will lead to perforator incompetence and will lead to varicose vein. Hope I think I answered every question right, I suppose. If any question is there, you can even contact me directly, man. No issues about it. I'll just post my contact details in this group even, the chat.
Sure, sir. Thank you so much, sir.
So any other questions are available?
Yeah, thank you so much, sir. And I would like to thank TNMSA also for arranging this session. If you guys have any doubt, you can just put down in the comment section in the YouTube so that sir will answer it. And in this time, I would also like to thank Dr. Balaji, from Professor of Pediatrics from SRM Medical College, who just sponsored this pro version of Zoom for this session. So I'd like to thank him. Thank you, sir. And thank you, speaker, and also to TNMSA.
Okay. Thank you, guys.
Thank you.
Thank
Thank
you,
you,
sir.
sir.
Thank you.